Okay, so Greg back here for another module. This is going to be on the autonomic nervous system. It's going to span 2 modules, and there's quite a bit of information in the autonomic nervous system. But so what I'm going to try and do is keep it very general at the beginning so that you get a really good understanding of the autonomic nervous system and how we use drugs for certain conditions that affect the autonomic nervous system. So the autonomic nervous system, remember, is the system that you're not typically consciously aware of what's going on, right? So things like respiratory rate, heart rate, how dilated your pupil is, digestive processes, things that you don't really need to be involved in from a minute-to-minute time frame. So the body has taken those functions and made them automatic or autonomic. Okay, and that takes a nervous system, and that's the autonomic nervous system. And there's feedback loops so that your heart rate is at a certain rate, your contractility of the heart, your digestion, all the things that you don't really need to be involved in because you have lots of other things to do in the day. Okay, and there's 2 parts of the autonomic nervous system, just in a general sense. There's a part that's like a gas pedal. That's the sympathetic system that turns up the autonomic nervous system. So that's more the stimulatory side of it, increasing heart rate, increasing the contractions of your heart, dilating your pupils, things that get you ready for action, okay, whether it's to run or to fight. That's why it's called the fight or flight system. And things that aren't required immediately, like digestion, are shut down, are turned off when the sympathetic side is activated. And then there's the more relaxation side, the parasympathetic. And this is the side that's more involved in digestion of food, peristalsis in your gastrointestinal tract, urinating, defecating, things that there's no urgency in terms of something is happening in your environment that you have to flee. So often, for example, sexual activity, the parasympathetic system is also involved. So it's more of a rest and digest system. Now remember that both of these systems are always on. Okay, it's not like one's off and one's on. And it doesn't go back and forth like a light switch. They're just on, they're just at different levels. Okay, so there's always a background of parasympathetic, but if the sympathetic is very high, then it's going to have much more influence. And the opposite is true as well. If the parasympathetic nervous system is activated, the sympathetic system is still on, but it's not having the same influence on the different organs. Okay, and that'll make sense as we go forward. So we need part of the brain to function as the control centers, and a lot of these functions come from the brainstem. We need nerves to be sent from either the brainstem or other parts that then innervate the different organs that need to be affected, not infected. So brainstem, sympathetic nerves, parasympathetic nerves, And then we're going to talk about some neurotransmitters that are typically involved in both systems. So let's just do a simple example to highlight both of the systems. So you're relaxing at home, watching a non-stressful movie, not some high-action movie, and you're on the couch. Everything is fine. Your heart rate is 65 or 70. Your blood pressure is 110 on 70. You're feeling relaxed. You're eating some chips and having something to drink. Nothing's going on. So the parasympathetic system is having more of an effect, right? So it's not how your system doesn't feel that it needs to be activated for any particular reason. But then you hear a noise outside your window, and then you hear a broken window, and a rock comes through. Well, that's going to activate your sympathetic system due to fear, right? Or surprise, something that's activated the sympathetic system. Your heart rate is going to go up. Your blood pressure is going to go up. The contractility, the strength of your heart pumping is going to go up. Your pupils are going to dilate so that you can see more of what's going on around you. Your digestion is going to immediately turn off. You don't need to be eating those chips or having anything to drink right now anymore. So it'll shut down the digestive process. If you had the sensation of urinating, you don't have it anymore, because something else, the sympathetic system, is shutting those non-essential systems down so that it can activate the systems that are essential for making sure that you remain safe. So that's usually the heart, your heart rate, your blood pressure, your eyes for vision, the activation of your brain so that you're exquisitely sensitive to your surroundings. So that would be activation of the sympathetic nervous system. Okay, so onto this quote here. I think it's a funny quote. So again, I know we're not on any particular slide with an image, but try to visualize a system that's always in the background of every human, that's doing functions for you so that it frees up your day to do other things, such as going to work, talking with other people, exercising, maybe just thinking, or planning. So all those things you can do, because in the background your autonomic system is maintaining vital functions. Okay, and those vital functions will always involve respirations, so that you're getting the proper amount of oxygen and getting rid of the proper amount of CO2. It's always going to involve the heart, so that you're maintaining a proper cardiac output, which is your heart rate and your stroke volume. And of course, stroke volume is the contractility. That's what decides how much blood you're pumping out of your heart. And that will also determine your blood pressure, which is very tightly monitored in your body, so that all the organs are perfused with blood. Okay. And then, of course, going a bit further, processes that have been deemed non-essential for you to be involved in are digestive processes like secretions of enzymes from your digestive tract, contraction of the gallbladder, uh, secretion of enzymes from the pancreas, and all those processes, including having a bowel movement or emptying your bladder, they're all heavily innervated by the autonomic nervous system. And some of them actually are more innervated than by the parasympathetic than the sympathetic. And the reverse is true. Some organs are more innervated by the sympathetic than the parasympathetic, and that will make sense as we go forward. So always just keep a general sense of the two systems, because you can really get bogged down with all the details otherwise. Okay. All right. Well, before getting to the autonomic nervous system, we're just having a quick electrolyte review / reminder. So potassium, normal levels of serum potassium are 3.5 to 5.0 milliequivalents per liter. And again, the body likes all of its parameters, all of its electrolytes, hemoglobin, white blood cells. It likes it in very tight parameters. It doesn't like them straying. And that's what we would call a homeostasis, right? The body's always trying to maintain homeostasis. So whether we talk about potassium, an electrolyte, or the pH of the body, or the blood pressure, the body is trying to keep it in very tight control so that it doesn't stray too far and then cause issues with organs. So all your organs are functioning to the best of their ability when all of these parameters are tightly controlled, such as potassium, which is the one we're going to talk about. So high potassium is probably the most concerning electrolyte disturbance that you should remember. High potassium is often deadly. Potassium is heavily involved in conduction of the electrical signal in the heart. And when you have abnormally high potassium levels, you'll get changes on your ECG, electrocardiogram, that we can detect as a possible hyperkalemia. You can run into dangerous dysrhythmias. So dysrhythmias is just another term for arrhythmia. So don't need to confuse those two, arrhythmia or dysrhythmia. So if high potassium, think, cardiac trouble, cardiac arrhythmias, and deadly cardiac arrhythmias. Okay. The other thing that potassium is heavily involved in is muscle contraction and muscle strength, right? Remember the action potentials. So if your potassium is highly abnormal, then you're going to run into muscular cramping, weakness, paralysis. Oliguria, meaning reduced urine production, is really I would think of it as the other way around. If you have reduced urine production, you can run into trouble with high potassium. Because if your kidneys aren't making urine, they're not secreting potassium or excreting potassium, and you can become hyperkalemic. Okay. The ECG change that is classically taught with hyperkalemia is tall peaked T waves. So what kind of things lead you to have high potassium, other than you suddenly deciding to consume massive amounts of potassium in your diet, which would be a bit unusual? Potassium is usually in very healthy food, so You'd have to consume lots and lots of healthy foods. And even then, if you have normal kidneys, your kidneys will get rid of the excessive potassium. So it's usually not from diet. So one of the most common causes is renal failure. So with renal failure, you accumulate potassium, um, and because it cannot be excreted by the kidneys. So renal failure is a big one for hyperkalemia. What else can cause you to have high potassium? What about if you have a severe muscle injury or a severe burn, a burn that burns deeply and damages and burns into the muscle, or a crush injury that has crushed thousands and thousands of cells? And remember, potassium mainly lives intracellularly. So suddenly, all this potassium is being released into the bloodstream, and it can't be immediately cleared by the kidneys. So you can develop hyperkalemia from a significant burn or a really bad crush injury. And in fact, a crush injury not only releases potassium, it releases a lot of other molecules into the bloodstream, including CK, creatine kinase, and you can get what's called rhabdomyolysis, where you release so many chemicals from this massive cellular death. Again, this can be from a severe burn or a crush injury, that your kidneys get clogged up with all of these molecules and CK, that you can go into renal failure from that condition. So I went off a bit there, but basically high potassium, think of kidney failure, significant crush injuries, severe burns, and DKA would be another one. Diabetic ketoacidosis. When you're acidotic, you trade your H+, your acid, for a potassium within the cell. And we'll come back to this if you don't get it this time. So you can become hyperkalemic in DKA. Okay? And as well, there's drugs that can make you hyperkalemic. So again, we'll come to these. There's drugs called ACE inhibitors, angiotensin II receptor blockers, spironolactone. They can also cause hyperkalemia. Don't memorize, we'll come back to it. Now, for hypokalemia, well, what causes your potassium to be low in the body? Well, that's usually from us. We do that because we typically give diuretics to certain people, such as in high blood pressure or congestive heart failure, where we want to remove fluid. A lot of diuretics actually drain you of electrolytes, and one of them is potassium. That's why people on diuretics need dietary advice on making sure they get proper potassium in their diet. So diuretic therapy is a big cause of hypokalemia. And then also just prolonged intravenous administration, like you're in hospital for some condition like pneumonia, you're on an IV, there's no potassium in the particular IV that you were given, and you just gradually, and you're not eating, and you gradually become hypokalemic just by dilution of the IV therapy. And remember, in general, remember cardiac and the nervous system has problems with high and low potassium, especially hypokalemia. It's cardiac issues and it's the nervous system. And if there's one thing that I would commit to some memory, although it's going to be mentioned many times, is There's a drug called digoxin that we're going to come to later. And digoxin and low potassium do not get along. It makes digoxin much more, it turns it basically into a super digoxin. It makes it too effective. And what makes low potassium? A diuretic. So often there's questions on person's on digoxin and now they're given a diuretic. What's the main concern? Well, the main concern is the digoxin being too effective in the setting of low potassium. Okay, we'll come back to that. Okay, so sodium is the next one. I'm not going to spend too much time on these. Otherwise, I'm going to really fill up. But I spent a lot of time on potassium. It's just a very critical electrolyte. Not that you don't. I mean, you still need to know about a bit about these. So I mean, basically the main electrolytes to know are sodium, potassium, and chloride, and calcium. You are going to hear about magnesium and chloride and phosphate and some other ones, but potassium is the big one. Sodium is important. Remember, sodium is the main extracellular electrolyte. Here are some of the symptoms of high sodium in the serum, and just some of the low sodium, so less than 135. And if you look at most of the ones with hyponatremia, it's typically nervous system. So try and group it into which organ's being involved with this particular electrolyte. So the nervous system is very sensitive to low sodium. Look at the changes. Mental status change, lethargy, confusion, all the way to seizures. And you can definitely get seizures when your sodium drops low enough. Okay. And when you look at high sodium, there's still some nervous system in there. Irritability, restlessness. Those are nervous system issues. But also there's a bit of cardiac too. Some high blood pressure, low cardiac contractility. So you have to try and group it into one or maybe two systems. Okay, so what about calcium? So again, calcium, you can see the normal range there. Hypercalcemia, that can be caused from a number of different issues. I'm not a big fan of mnemonics. I'm not good at memorizing things. I need to understand things, but there is a mnemonic for hypercalcemia. Stones, bones, abdominal moans, and psychic overtones. So high calcium will give you kidney stones. It will give you weakened bones because you're removing calcium typically from your bones. That's where your calcium stores are in your, I think 95 or 96% of your calcium in your body is stored in your bones. So the bones will become osteoporotic. High calcium gives you abdominal pain, okay? And it also causes mental status changes, the psychic groans. So stones, bones, abdominal moans, and psychic overtones. Okay, so there's a couple of other things here that, muscle weakness, for sure calcium is involved in muscle contractility, diminished deep tendon reflexes. Well, if your muscles aren't working, your reflexes aren't going to work very well because the reflex is based on muscle movement. And then the other one's mental status change and kidney stones. You'll remember in the mnemonic. Hypocalcemia, just find what system is it. This is really looking like the nervous system is getting upset, right? Convulsions, that's seizures, arrhythmias. So you need calcium for proper conduction in the heart, so you can run into arrhythmias with it. tetany, that's severe muscle spasms. Positive chopsticks and Trousseau sign will come to increased deep tendon reflexes. Okay, so the nervous system is actually becoming very irritable and twitchy with muscle spasms, seizures, increased deep tendon reflexes compared to hypercalcemia. Okay, so let's just do a little review here because it'll come into play when we're talking about the two sides of the autonomic nervous system, the sympathetic and the parasympathetic. So you have a neuron, and you can see the dendrites up and to the right there, which connected to other neurons. And then there's the cell body. And then we're going to go along the neuron where the action potential travels. So it travels from the cell body along the neuron to the synapse. And the action potential at the synapse stimulates the release of a neurotransmitter that's going to cross the synaptic cleft between the neuron and whichever organ it's attaching to. So whether it's a muscle to cause a muscle contraction, or whether it's the cardiac, well, the cardiac's a muscle too, but whether it's the cardiac electrical circuit to adjust the heart rate, just depends where this particular neuron is going. So what's going to be different between the two systems? So you're still going to have a nerve with an action potential going along it, whether it's the parasympathetic or sympathetic. You're going to have neurotransmitters stored in vesicles at the end of the nerve. The action potential is going to release neurotransmitters, and the neurotransmitter is different on the two sides. So in general, the parasympathetic neurotransmitter is acetylcholine. Okay, so those little tiny green balls that are being released there, if it's the parasympathetic system, it's acetylcholine. If it's the sympathetic system, it is usually norepinephrine. Okay, and we'll get to those. So there's a difference right there. The neurotransmitter is different. So it's going to attach to a different receptor, and the receptor is then going to cause a different action because a receptor that's stimulated by acetylcholine from the parasympathetic system is going to have a different effect than a receptor that's stimulated by norepinephrine of the sympathetic system. So next slide here, the nervous system. So the nervous system is broken down into the central nervous system and the peripheral nervous system. The central is basically the entire brain and the spinal cord. The peripheral nervous system are all the nerves that are leaving the brain. So that would be cranial nerves that are leaving the brain, or all the nerves that are leaving the spinal cord. Okay, that's the peripheral nervous system. It's going out to the periphery. And the peripheral nervous system has two functions. It either wants to send a signal from the brain to the periphery, such as a muscle or the heart or glands or the intestine, or to move your legs. So that's the motor division. Okay, it's trying to activate something or have you move, or so it's carrying the impulse from the central nervous system to the muscles or the glands or whichever. We'll get into more detail. Or the sensory division, which is giving information to the brain from the periphery. So whether it's your skin on the bottom of your foot, that you're feeling maybe a stone in your shoe, or you're sitting on something hard and you're uncomfortable, or you're experiencing pain somewhere, that's all information the brain wants to know about. Okay, so that's the sensory division. So the motor division, so the information leaving the brain and going outwards, is of two types. There's the somatic nervous system, meaning you want to grab your cup of water to drink. You can do that voluntarily. You can think about the action, and then your arm and your hand will move to grab the cup of water. Or you want to move your leg. Same thing. That's the somatic nervous system. It's voluntary to skeletal muscles. And then it gets broken down into the autonomic nervous system, which controls all the autonomic responses that we've spoken about, whether it's cardiac muscle, the respiratory system, secretions from glands all over your body, such as in your mouth, in your digestive tract. That's all autonomic. Your pupillary, the size of your pupils, that's controlled by the autonomic nervous system. Okay, and that makes sense because that whole system is doing it in the background, but it's a motor division. It's sending signals out to all these parts of the body without you having to get involved. And there will be feedback loops, but they're not necessarily they're not really sensory nerves coming back. So that's why the autonomic nervous system is considered part of the motor division. Okay, and then the autonomic nervous system has two sides that we've spoken about. The sympathetic division that prepares for stressors of the body. You're going to engage in something energetic, like going for a long run. You're suddenly frightened, anything like that to alert the body that something is happening. Pain will activate your sympathetic nervous system. Fear, hypotension, so low blood pressure, you are bleeding. That's going to activate your sympathetic system to turn on to do something to try and maintain blood pressure. Because remember, blood pressure was one of those vital signs that the autonomic nervous system wants to keep in check. And then the other side is the parasympathetic system, which is performing all the functions while you're taking it easy, resting, your digestion, your urination, your bowel movements, all those things are parasympathetic. Okay, and the sympathetic system uses what are called adrenergic receptors. So at the end of those, where we just saw the nerve and the synapse attaching to a postsynaptic organ or muscle, it uses adrenergic receptors to accept norepinephrine as the main neurotransmitter. And those receptors are broken into alpha and beta, and we'll come back to that. The parasympathetic system it uses cholinergic receptors. So if you say the cholinergic system, so acetylcholine, so cholinergic, you're referring to the parasympathetic system. So acetylcholine is the main neurotransmitter, and we call the receptors cholinergic receptors or muscarinic. And the reason we call them muscarinic is they respond to a chemical called muscarine, and there's nicotinic receptors that respond to nicotine. But the main receptors of the parasympathetic system are cholinergic, or in quotation brackets, muscarinic receptors that are stimulated by acetylcholine. Okay, so here's a review slide: neurotransmitters and the autonomic nervous system. So in terms of neuropharmacology, meaning drugs that impact the nervous system, the autonomic nervous system, we have a lot of drugs for it. It's a very complicated system, but we'll get through this. Just try and keep them clear in your mind. I find if you don't get it after the first run through, listen to it again. Don't go through the whole semester not understanding the autonomic nervous system, because it comes up everywhere. And then you always find yourself having to think back. It's like, oh no, is it a beta receptor? Is it an alpha receptor? Oh no, and what does this drug do? And so really try and get a good handle on it near the beginning, okay? So what kind of drugs impact the autonomic nervous system? So just think of the autonomic nervous system at the moment as part of the brain, okay? And it is. It's a section that we've decided to split off and called the autonomic nervous system, but it's still a part of the brain. So look at the functions, look at the treatments that we have. So to treat pain, well, that makes sense. Pain is interpreted in the brain. Anxiety, depression, schizophrenia, sleeplessness like insomnia, seizures, heart rate control, rhythm control, so antiarrhythmics, blood pressure control, hypertension, glaucoma of the eye, so drops or drugs for that, asthma of the respiratory system, runny nose, so we can use some autonomic type drugs for nasal discharge or allergic rhinitis, things like that. So you can see a lot of these are brain related diseases and conditions that we can treat with certain drugs, okay? So autonomic nervous system, again, remember it's part of the peripheral nervous system, and it regulates things without your input, okay? And we've listed some there: your heart rate, respiratory rate, blood pressure, gastrointestinal tract, genitourinary tract, and pupils. So all of those have influence of both sides, the sympathetic and the parasympathetic systems. Okay, so I've said this on other slides, but you know what? It's okay to be repetitious with this kind of stuff. It just helps you digest it a bit more. Okay, so the autonomic nervous system are nerves that provide stimuli for involuntary control of vital functions. So involuntary, not requiring your input, of vital functions of the cardiovascular system, which is blood pressure control, heart rate control, cardiac output control, the digestive system, when it gets activated, when it secretes digestive enzymes, when it turns off, what activates it. The autonomic nervous system is heavily involved in that. The respiratory system. Do you need to breathe faster because you're exercising and you're producing more CO2 from cellular metabolism? Or do you need to breathe slower because you're sleeping? Does your blood pressure have to be higher because you're activated? You're running from something. You're fearful. Or can it be lower when you're fast asleep in the middle of the night? The genitourinary system. That's sending a signal to the bladder to contract. So whether it's contraction of your bladder so you can urinate, whether it's constriction of your blood vessels so that your blood pressure is maintained. So if you constrict blood vessels all through your body, there'll be less flow leaving the main systemic circulation. Your blood pressure will be maintained. Or to contract or dilate or bronchodilate in your lungs. Your eye, we mentioned, the pupil, the pupillary size. Okay, cardiac muscle contraction, again, autonomic. Secretion of salivary fluids, sweat, gastric juices. All these things are from the autonomic nervous system. And remember, knowing the receptor locations and the action of the sympathetic and parasympathetic systems will let you know what each individual drug will do. Okay, so if you know where these receptors live, the drug can't work if the receptor isn't on a particular organ. Okay, so let me give you an example. If I inject you with norepinephrine, which is the sympathetic neurotransmitter, it's going to go to organs that have those receptors, such as your heart and your blood vessels and your pupil. It's not gonna, it can't act on places where the receptor doesn't live. Okay, so it's all about the receptors and where have the receptors been put in a human so that the epinephrine on the sympathetic side, or the norepinephrine, or the acetylcholine on the parasympathetic side acts on those receptors and affects those particular organs. Okay, so let's, this is figure 12-2. So I think if you have a really good feel for this slide and where the parasympathetic and the sympathetic nervous systems are going and which organs they're affecting, things will, this will be really helpful going forward. So just in general, let's just have a look at where the two parts of this nervous system, the autonomic nervous system, are coming from. So the parasympathetic division is really leaving from the brainstem in the form of cranial nerves. Okay, so there's cranial nerves, for example, cranial nerve 3 can go to the pupil. There's a very large cranial nerve called the vagus nerve, the vagal nerve, that's cranial nerve 10. And that's a huge nerve that goes throughout many parts of the body to innervate different organs that we'll see as part of the parasympathetic nervous system. Okay, so it comes from, essentially the parasympathetic system comes from cranial nerves, and then at the bottom it comes from some sacral nerves to innervate the bladder and the sexual organs. Okay, now let's go look at the sympathetic division. They are essentially coming from the thoracic and lumbar spine. Okay, so there's a sympathetic chain of nerves that follows the spinal cord downwards, starting in the lower cervical nerves and ending in the lumbar area. And that is where the sympathetic chain is, and it's giving off nerves, so sympathetic nerves to different organs as well. And if you look at the organs on each side, parasympathetic or sympathetic, they're very similar, right? They're acting on the same organs. They're stimulating or relaxing the organ, and they're having different actions on the organs. So this is all about where the receptors are. You don't see any organs on here that don't have receptors. So for example, you don't see teeth on here. You don't see hair on here. You don't see the function of the ear on here. There's no receptors there. So it's all about where these receptors have been implanted, or through embryology, through just millions and millions of years of development, where the receptors of the parasympathetic and sympathetic nervous system exist. So what we're going to do now is go through the parasympathetic and the expected effects if the parasympathetic division is stimulated. And then we'll go to the sympathetic division and what to expect when the sympathetic division is affected. And remember, whenever I say parasympathetic, it means that acetylcholine is the neurotransmitter going from the nerve to the end organ. Whether it's the eye, the heart, the lung, whatever, it's acetylcholine. And when we talk about the sympathetic system, it's typically norepinephrine. Sometimes it can be epinephrine. They're very, very similar, and they have very, very similar receptors as well. Okay, so let's start with the parasympathetic system. Sorry if there's a bit of background noise here. I have a squeaky chair today. So the parasympathetic system. So you're not under stress. You're not under anything that's activating you. Think of yourself as, sitting down, relaxing, maybe eating something or drinking something. Nothing stressful. So your pupils don't need to be dilated. They can constrict. You don't need a large peripheral vision to see if someone's chasing you or if there's something in your peripheral vision that you need to keep an eye on. So your pupils don't need to be actively opened. Your salivary glands can be activated, especially if you've put food in your mouth. You need that saliva to start breaking down the food, right? Saliva not only lubricates food, but it has the beginnings of digestive enzymes like amylase in the saliva. And now we're looking at the huge vagus nerve going to all kinds of organs: heart, lung, stomach, gallbladder. That's all vagus nerve, cranial nerve number 10. It's a huge nerve. So what does it do at the heart? Well, it slows down it slows down the heart rate by slowing down the SA node impulses. So reduced heart rate, reduced contractility of the heart. And remember, this is all with acetylcholine at the synapse for the parasympathetic system. The lungs, well, you don't need to have wide open bronchodilated lungs. You can have a bit of bronchoconstriction. So the parasympathetic nerve bronchoconstricts a bit, saying you don't need to be wide open. The digestive system, really starting from the mouth downwards, you're gonna have increased peristalsis of the esophagus. You're gonna have secretions of stomach enzymes, pancreatic stimulation to release pancreatic enzymes, contraction of the gallbladder to secrete bile, increased peristalsis of the small intestine. So the whole digestive tract is being activated by the parasympathetic system for the arrival of the food to digest and absorb. And the sacral part of the parasympathetic system is for contraction of the bladder. So when your bladder fills enough, a signal will be sent from the bladder itself, and there'll be a feedback loop that will cause contraction of the bladder in the appropriate setting. So we have a valve or a sphincter at the bottom of the bladder that we can hold tight. So even if you do need to urinate, you can hold it until you get to the toilet, unless you're a young child. So contraction of the detrusor muscles of the bladder is a parasympathetic function. Stimulation of the sexual organs. So in women, it'll cause increased contraction and peristalsis of the fallopian tubes to move the egg along. potentially. Increased lubrication of the vagina and the cervix. In the male, it will fill the penis with blood to create an erection. Okay. So now remember, you don't have to activate this entire system. The parasympathetic system can choose what it wants to activate and inactivate. So it's not like all of these things have to happen at the same time. Okay. The sympathetic division is the activation side. Okay, so this is the thoracic and the lumbar sympathetic chain, where it's starting. And so what does it want to do? It wants to make you hyper aware of your surroundings and vigilant. So it's going to dilate the pupils so you have a fantastic peripheral vision. It's going to shut down the salivary glands and the digestive tract. It's not required right now. And that's why when you're really scared, you have a dry mouth, right? You feel like you could drink some water or something because you've had a fright. It activates the heart to increase contractility and heart rate. And remember, the neurotransmitter is norepinephrine at the receptor site. It bronchodilates the bronchial tubes, making them much wider for more airflow in and out. It inhibits the stomach contractions, secretion of enzymes, basically shuts down the gastrointestinal tract. And the liver, it's going to activate gluconeogenesis, right? It's going to activate glycogen breakdown to glucose with the expectation of having to use this glucose as energy right away. Okay. It also stimulates the kidney to secrete. Well, actually, in this image is showing that the sympathetic system is stimulating the adrenal gland, which is on top of the kidney. And why is it doing that? Well, the adrenal gland secretes epinephrine and norepinephrine as well. So now you have norepinephrine and epinephrine not just at your neurotransmitters at all these different sites, but now in your bloodstream. It's circulating everywhere. And that's going to activate your brain. It's going to make you hyper alert. It's additional epinephrine and norepinephrine in the whole system now. It tends to inhibit sexual organs. Okay, and that kind of an odd way to think of it. The stimulating system inhibits the sexual organs, except for ejaculation. So the sympathetic system is responsible for ejaculation in males, but otherwise it tends to inhibit the sexual organs. Okay, so drug classes now. So when you're starting this, try and refer back to that slide that we just did with the divisions of the parasympathetic and sympathetic, and think about. So there's two divisions, right? There's the sympathetic and parasympathetic. So you can do two things to each side. So there's going to be 4 drug classes. So on the sympathetic side, I can stimulate it or I can inhibit it. Okay. On the parasympathetic side, I can stimulate it or I can inhibit it. So there's 4 drug classes depending. So if we're going to go through them, so a cholinergic agonist is the same as saying a parasympathetic agonist or a parasympathetic stimulator. Okay? And you can see all the different names there. They all mean the same thing. Cholinergic agonist, parasympathomimetic. A mimetic is something that mimics something, or a muscarinic agonist. Remember, it's a muscarinic receptor that we spoke about. So it's a muscarinic agonist because you only get muscarinic receptors in the parasympathetic. Okay, anticholinergic. So anti-parasympathetic. Well, that's called parasympatholytic, meaning I'm going to inhibit the parasympathetic system, or a muscarinic antagonist. I'm going to inhibit the parasympathetic system, or a cholinergic blocker. By far the most common term is anticholinergic drugs, or yeah, that would be the most common. But know the other terms as well, because they mean the same thing, okay? On the sympathetic side, there's adrenergic. So adrenergic is another name for sympathetic, and it's based on one of the neurotransmitters called adrenaline, and adrenaline is just epinephrine. So what are the two neurotransmitters? Epinephrine and norepinephrine. So adrenergic agonist is something that stimulates the sympathetic system, so a sympathomimetic. Another term for it is actual chemical makeup of norepinephrine or epinephrine, and there's another one called dopamine. Those are the chemical makeup of them. They're called catecholamines. Okay, so if you say adrenergic agonist or sympathomimetic, or I'm going to use a catecholamine, it means I'm going to stimulate the sympathetic nervous system. Now, what about a sympathetic system blocker? So that's an adrenergic antagonist, or a sympatholytic, or an adrenergic blocker. Okay, so they all have the same term. You'll see them used a bit interchangeably. Just know that there's 4 drug classes, but know the different names of them too, because they can confuse you with a question that says, a muscarinic agonist is. So know that there's a bit of a difference, that there's different names, but they mean the same thing. And remember, parasympathetic system, the neurotransmitter at the end is acetylcholine, right? And on the sympathetic side, it is epinephrine or norepinephrine that's making its way across the synapse to bind with a receptor. Okay, so division controls here. So here's a bit of a quote. So under most conditions, the 2 branches of the autonomic nervous system cooperate to achieve a balance of readiness and relaxation. So it's not an on-off, it's a balance of both. One might be a bit higher, one might be a bit lower. Okay, and because they have basically opposite effects, you'll see that sometimes they don't have total opposite effects, but for the most part, they have opposite effects. So then there's a homeostasis, and homeostasis means balance, right? And the body is always striving for balance in everything, in blood pressure, in heart rate, in serum glucose levels, electrolytes, kidney function tests, everything. The body wants it to be in homeostasis. Okay, so a bit of an example with these 2 systems that are opposing each other a bit, they're giving perfectly fine balance to every organ that they're innervating, so that they're in complete control of the gas pedal, the sympathetic system, and the brake pedal, which is the parasympathetic system. Now, typically you're not supposed to drive with 2 feet, one on the brake and one on the pedal. But in this case, I think that analogy makes a lot of sense. You have a bit of gas going, you got a bit of brake pedal going all the time. If you really want to overcome the brakes, you'd give it lots more gas with the sympathetic system. If you really want to overcome the gas, you'd give it a lot more brakes with the parasympathetic system. Okay, so let's look at the sympathetic division here of the autonomic nervous system. And it's called the fight or flight, right? Because whether you're going to fight, say you're in a fight with a wild animal, or you're being mugged in a back alley, you're going to fight or you're going to run. And both of those need increased activity of many organs, such as the heart, the lungs, the pupils. The brain needs to be activated. The adrenal glands secrete epinephrine and norepinephrine right into the bloodstream. The blood pressure has to be maintained or even higher than normal. You're going to be tachycardic. And on top of that, it's going to shut down systems that are not required. The gastrointestinal system, the secretions from glands, any system that does not need to be involved in this fight or flight response. Okay, so the sympathetic system goes to all these different organs and acts on them directly, but it also goes to the adrenal gland, which stores a lot of epinephrine and norepinephrine. And when this gets secreted into the bloodstream, you have not only direct stimulation to individual organs through nerves, but now you have bloodstream stimulation from epinephrine and norepinephrine having been secreted by the adrenal gland, which is going to lead to more pupillary dilation and heart rate and increased contractility by the heart, and bronchodilation of the lungs, stimulation of release of glucose from the liver, and then shutting down all the non-essential areas of the body, like salivation, digestion, bladder contractions, and sexual organs. Okay, so this is just a typical, so we're gonna look at adrenergic agonists or sympathomimetics. And basically these are stimulators of the adrenergic system or the sympathetic system. Okay, so we're looking at norepinephrine and epinephrine at the synapse that's going to attach to a receptor on the other side, depending on which organ we're talking about. So an action potential comes down the nerve. In this case, it's going to be a sympathetic nerve. It's going to stimulate release of the neurotransmitter that's contained within vesicles. And the neurotransmitter is going to be released into the synaptic cleft and migrate across the synaptic cleft to attach to the norepinephrine receptor and cause an action at that site. So just depends on which organ we're talking about. Now, the norepinephrine at some point has to be broken down, right? It can't just stay in the synaptic cleft indefinitely. Otherwise, it can't be cleared for another signal that's going to come potentially in a couple of seconds or half an hour. So it needs to be cleared or reabsorbed by the presynaptic nerve. So once norepinephrine has stimulated the norepinephrine receptor. Sorry about that. I was stuttering there for a while. The presynaptic neuron can reabsorb it with transporters, so it can reuse the norepinephrine for another stimulation, or it gets broken down in the bloodstream by an enzyme called COMT. Okay, and that enzyme is catechol-O-methyltransferase. I wouldn't memorize that. I don't think it's a very important enzyme. Maybe if you just recognized the initials of it, it's basically you need to clear this synaptic cleft for the next signal, and that is the enzyme that breaks it down in the bloodstream. So you can already see that if I was to use a drug that stopped reabsorption of norepinephrine, say it's site number 3 there, inhibition of norepinephrine reuptake, I could make more norepinephrine at the and remain longer in the synaptic cleft, right? Or if I could somehow stop the breakdown of it with a drug, I could keep more norepinephrine there. So think of it. I'm not going to mention a specific drug right now, but that's ways that we can use drugs to affect the sympathetic or the parasympathetic nervous system by affecting either the receptors, say by stimulating the receptors with a mimic type drug, or blocking the receptors. There's all kinds of options, and it'll become clear as we start to do different drugs. Okay, so this next slide could be potentially frightening, and it could activate the sympathetic nervous system in you, which will, remember what that does? Dilates your eyes, activates you, gets your heart rate racing, could make you sweaty, increases your blood pressure. So it'll activate a lot of those. And how will it activate that? So say I have some drugs that are adrenergic agonists. So basically I have a drug that behaves just like what you have in your body, norepinephrine or epinephrine. Okay, so that group is also called catecholamines. So we actually have catecholamines in hospitals, so that we can stimulate the sympathetic nervous system in a variety of conditions. And we have epinephrine, and you may know that that's already used for anaphylaxis. It's used for hypotension, and we'll come to that in more detail. Another catecholamine is norepinephrine, and we use IV norepinephrine all the time to maintain someone's blood pressure when they're hypotensive due to sepsis or some other condition in their bloodstream. It's usually something infectious. They're making them extremely hypotensive. So we'll use norepinephrine to maintain blood pressure. We use dopamine to increase contractility of the heart. So it's a drug that's going to increase not only the heart rate, but the contractility of the heart. Okay, and beside these drugs, you see alpha-1, alpha-2, beta-1. That's because the sympathetic nervous system has 4 types of receptors. Okay, so catecholamines are just a group of drugs that are available to give people, and so are, by the way, direct sympathomimetics. They're just direct stimulants. Okay, so we also have those available to us as well. And so it just totally depends on which receptor it likes the most. So let's look at norepinephrine. And I wouldn't start memorizing which receptor is stimulated more by norepinephrine versus epinephrine. We'll come to a bit of that later, but let's just look at norepinephrine. So in brackets beside it, it says it's an alpha-1, an alpha-2, and a beta-1 agonist. So it's stimulated. Okay, it stimulates those receptors. So wherever those receptors are, it's going to stimulate them. Okay. So I'm just gonna tell you on the side here, norepinephrine is a very, very powerful alpha-1 agonist or alpha-1 receptor stimulator. And where do we find the majority of alpha-1? On your blood vessels throughout your entire body. And so when we stimulate blood vessels with norepinephrine, we force them to vasoconstrict, to tighten and close. And that maintains the central blood pressure, because all the little capillaries, all of your body are now vasoconstricting, so it maintains blood pressure. And that's why we use norepinephrine to maintain someone's blood pressure, because it's a very powerful alpha-1 agonist. That's just an example. So what about epinephrine? Well, epinephrine, epinephrine happens to like all receptors the same. Alpha-1, alpha-2, beta-1, beta-2. And this is a perfect example of why we use it in anaphylaxis. It vasoconstricts all the blood vessels as alpha-1, and that brings your blood pressure up. Let's leave alpha-2 alone for a minute. Beta-1 is almost exclusively in the heart. So if it stimulates beta-1, what's it going to do? It's going to increase heart rate and increase contractility, because that's where the beta-1 receptor lives. And beta-2 lives almost exclusively in the lungs, in the bronchial tubes. There'll be some occasional exceptions that we'll come to, but let's just keep it at this level for now. So what's it going to do to a beta-2 receptor? It's going to bronchodilate the bronchial tubes. So it's a perfect drug for anaphylaxis, where you get wheezing, bronchoconstriction, low blood pressure, swollen tongue, swollen lips, this diffuse body rash. It helps with all of them because it's a very effective alpha-1, beta-1, and beta-2 receptor agonist. Okay, so those are just examples. We'll come to other ones, but so now you know that there's 4 different receptors, and the receptors are sprinkled in different parts of the body. So remember, alpha-1 is typically all over the blood vessels. There's also alpha-1 in the prostate gland, and we'll talk about those later. The alpha-2 they're almost exclusively in the brain, and that's why they're not as important. We'll get to them, we'll talk to them about it a bit, but alpha-2 is the least important of all of them. Beta-1, heart, okay? Heart has by far the most beta-1 receptors. Beta-2, lungs, okay? The bronchial tubes to bronchodilate. And there are some beta-2 receptors in the kidney. Now, as we go on, there are some other sites that have some of these receptors, and we'll get to them on a case-by-case basis. But just to keep it simple right now, alpha-1, blood vessels, alpha-2, it's in the brain. It does some weird things in the brain. We'll explain that. Beta-1, mainly the heart, tiny bit in the kidney. Beta-2, mainly the lung, and a tiny bit on the blood vessels and some other areas, and we'll focus on those later. You don't just understand where the receptors are. Don't memorize which drug right now impacts which receptor. That would be way too confusing. And if you know where the receptors are, it won't matter when you give a sympathomimetic, because you'll know where the receptors are and they'll be stimulated, and you'll know the action, okay? Indirect sympathomimetics stimulate the release of stored norepinephrine. Well, these are, so that's how amphetamine works, right? So it blocks, so cocaine, for example, blocks the reuptake of norepinephrine. So what do? You get this tremendous surge of norepinephrine at the synaptic cleft. Tyramine will come to at a later stage. That has to do with MAOI inhibitors. And then when we're talking about blockers, so in this case we're talking about adrenergic antagonists, so sympatholytics. They're going to block the sympathetic system. So you're going to have alpha blockers and you're going to have beta blockers, depending on what the drug does. Does it block the alpha receptors of the sympathetic nervous system or the beta receptors of the sympathetic nervous system? And we'll come to those. Okay, so I wouldn't stare at all those drugs and just feel a bit ill from seeing them all. Just understand that there's 4 receptors, 2 alphas and 2 betas. They're located in different parts of the body, and the sympathetic nervous system with norepinephrine and epinephrine, and also drugs that we can give, can preferentially affect some of those receptors more than others to get the desired effect that we want out of the drug. Okay, and that goes along for the blockers too. Okay. Okay, so here's a page that is good to refer back to really know where the receptors are, because when you know where the receptors are, you know that when you give a certain drug or when the body releases epinephrine or norepinephrine, it's going to have an effect at these sites. So if I say I'm going to give an alpha-1 agonist, I can just think of all the places where an alpha-1 agonist works. I'm going to give a beta-1 agonist. Well, I know beta-1 is basically the heart. I'm going to give a beta-2 agonist. Okay, so it just depends. So each drug that we might use, it will have a preferential receptor that it likes. Okay, so let's go through a couple. Let's go through this slide a bit more, because it's kind of important. Because later on you're going to say, well, you know, a patient's been given a beta-2 agonist. What do you expect will happen? Or a patient's been given an alpha-1 antagonist. What's going to happen? Okay, so we'll go through each one of these 4 receptors and talk about them a bit. So let's pretend that I'm injecting someone with epinephrine. And epinephrine stimulates all 4 of these receptors throughout the body. So I'm injecting someone into the bloodstream with a bit of epinephrine. So I'm going to stimulate all 4 of these receptors. And then let's go through the effects of this sympathetic stimulation. Okay, so let's see where the alpha-1 receptors are sprinkled. And that's where the effect will take place if you have an alpha-1 agonist or a stimulant of these receptors in the sympathetic system. So they're definitely on the blood vessels. So when they're stimulated, they're going to vasoconstrict. So vaso is another word for vessel, and constriction is closing. So vasoconstriction. And when you vasoconstrict many vascular beds throughout your body, you're going to get a rise in blood pressure. You'll maintain your blood pressure because it's not going through all those vessels. You're going to get an increased peripheral resistance. Well, because all the little tiny blood vessels are now much smaller, it's more difficult for blood to get through those little tiny vessels. So the resistance for the blood to get through is much higher. Mydriasis, which is a dilated pupil. Well, there's alpha-1 receptors on the iris, and so you get a dilated pupil. And what else do you get? So, and I'm not sure if you remember, but I said that alpha-1 receptors are in the prostate as well, and this will make more sense when we get to other drugs that we use for the prostate. But alpha-1 receptors in the prostate will cause increased closure of the little valve, the sphincter, that's just at the lower part of the bladder. Okay, so that'll hold your urine. So if I give you an alpha-1 stimulant or an agonist, it's going to tighten that sphincter and make it even more difficult to urinate. What happens if I have an alpha-1 antagonist when I'm talking about the bladder? Well, I can relax that sphincter by blocking the alpha-1 receptor. And so I can make it easier for someone with a large prostate to urinate because I'm relaxing with an alpha-1 antagonist. So that's just an example, but we're going to keep to the stimulation part. So now we're going to skip alpha-2 for a minute, and we're going to go to beta-1. Okay, so where are the beta-1 receptors? Well, they mainly live on the heart and a bit on the kidney. And so what am I going to expect if I stimulate them? Well, tachycardia, okay. Increased heart contractility, because the beta-1 receptors are on the myocardium, on the heart. They're also a bit on the kidney. So when the kidney is stimulated by the sympathetic system, it releases renin into the bloodstream. And there's increased lipolysis. So there's increased fat breakdown. So there's beta-1 receptors on the fat cells and in the liver to stimulate fat breakdown. And why would you want to do that? Well, the body is sensing that it's going to need energy. So by breaking down some fat with these beta-1 receptors when they're stimulated, it's guaranteeing that it has energy to be used for whatever you're doing. Okay? Why would you want to release renin from the kidney by stimulating it with your sympathetic system? Well, the body's getting ready for some kind of fight or flight response. So renin, when it's released, I'm not sure if you've done this in class, but the renin-angiotensin system. If you haven't, don't worry about it. If you have, then it'll make sense. Renin converts angiotensinogen to angiotensin 1, and then angiotensin 1 is converted to angiotensin 2, which is a very powerful vasoconstrictor. So by stimulating renin release, you're producing angiotensin 2, which is also going to vasoconstrict your blood vessels just to make sure that you don't become hypotensive, low blood pressure. Because the whole aim of this system is to make sure that your vital signs are maintained. And one of your main vital signs is your blood pressure, right? Because your brain needs blood. So your body's always going to want to maintain blood pressure. Okay, so what about beta-2? So don't forget, we're in the setting of some kind of stress happening. Either someone's chasing you, or something upsetting has happened, or you're under duress because of an exam. This is the activation of this system, or you're in a car accident. So beta-2, well, look, if you stimulate the beta-2 receptors, so some drugs are very specific to beta-2, well, you're going to cause a bit of vasodilation, okay, especially in the muscles. So the muscles of your body, so where the blood vessels are going through the muscles, you're going to vasodilate them, okay, and we'll get to the reason why. A slight decrease in peripheral resistance. Well, if you're vasodilating some of the blood vessels that go through your muscles, then the resistance will go down, okay? And in actual fact, you could get a slight drop in blood pressure even if your peripheral resistance goes down. So anyways, so that's beta-2 on the blood vessels. And I'll explain why in a minute. So bronchodilation, okay? Your bronchioles are dilating. That makes sense. You want to get more air in and out of your lungs because you're under some kind of stress. Increased muscle and liver glycogenolysis. So breakdown of glycogen to sugar in the muscles and the liver so that you have ready energy to be used for whatever you need to do. Like, for example, run fast or some kind of activity that you need to do immediately. And there's also beta-2 receptors on the uterus. And when they're stimulated, they relax the uterine muscle. So if I give someone a beta-2 agonist, I'm going to bronchodilate in their lungs. I'm going to potentially release some sugar into the bloodstream from the liver. I'm going to relax their uterus. So say they're pregnant and they're in preterm labor, I can help stop that with a beta-2 agonist. And I'm going to vasodilate their blood vessels going to their muscles. And why would I want to vasodilate specifically the muscles? Well, if you don't vasodilate the muscles, remember the alpha-1 receptors are vasoconstricting all the non-essential parts of the body in the fight or flight response. So vasoconstriction of the skin, so you're going to be pale. Vasoconstriction of the gut, the gastrointestinal tract, so it's not going to function for you during a sympathetic response, because these are deemed non-essential emergency parts of the body. But muscles are definitely essential in order to run or to exert yourself. So the body has put beta-2 receptors there, so they vasodilate in the muscles, allowing proper blood supply to the muscles so that the muscles can continue to function. Because without blood supply, the muscles can't function. So that's why you have beta-2 receptors there. Okay, so this next slide is the concept of just definitions of inotrope, chronotrope, and dromotrope. And there's drugs in the sympathetic system so let's just talk about the definitions first and we'll get it. So an inotropy means the contractility of the heart. How hard is the heart? How forceful is it contracting? So if you're a positive inotrope drug, you're going to help increase the contractility of the heart. If you have a negative inotrope drug, you're going to reduce you're going to weaken the contractility of the heart muscle. Okay, so we like to know these because depending on what drug we use, we'll know whether it's a positive or a negative inotrope. Chronotrope, well, chrono means time. So chronotropic, if you're a positive chronotrope drug, it means you're going to increase the heart rate. A negative chronotrope drug, reduce the heart rate. And then lastly, dromotrope just has to do with the electrical conduction in the heart. And if you have positive dromotropy, it means that it helps the conduction be even more efficient in the heart. If it's negative chronotropy, it means it's going to slow down the electrical conduction in the heart. Okay, so most of the time, if we're talking about one particular drug, let's talk about epinephrine. Epinephrine is a positive inotrope. Okay, it increases the contractility of the heart. Is it a positive chronotrope? Yep, it increases the heart rate. Is it a positive dromotrope? Yes. So it increases all three of those. Okay. The only drug that doesn't follow this, and don't worry if you don't remember it now, because we're going to talk about this drug later, is digoxin. So digoxin happens to be a positive inotrope, so it helps contractility of the heart, But a negative chronotrope and a negative dromotrope means it slows down the heart and it slows down the electrical conduction. Okay, so it's nice to know what the drug does in terms of these things, inotropy, chronotropy, and dromotropy, because then we can predict what's going to happen when we give this particular drug. Okay, and there's some drugs that have negative inotropy, negative chronotropy, and negative dromotropy. So they slow down the heart, they reduce contractility, and they reduce conduction. So, but usually they're either all positive or all negative, except, as I said, for digoxin. And we'll get into that a bit more. Just know the concept of the terms. Okay, so back to adrenergic receptor types. Remember, it's all about the receptors. If you know where the receptors are, you'll be able to predict what's going to happen, and you'll also be able to predict the side effects of the drugs, because the side effects are going to be from stimulating receptors that you didn't really want to stimulate with the drug, but you had to because the drug you gave went into the bloodstream. So you can't really be specific with the drug. So alpha-1 receptors, where are they mainly? So all sympathetic target organs except the heart. So they're mainly on the blood vessels and the pupils. Okay. So they vasoconstrict the blood vessels except in the muscles. Remember? The beta-2 agonists vasodilate those so you can maintain blood flow to your muscles while you're running away. They dilate the pupils so you have a better view of what's happening in front of you, better peripheral vision. The alpha-2 receptors I've kind of avoided talking about. They're the least important, but they seem to come up every once in a while anyways. So they're in the brainstem, okay? So these receptors live in the brainstem. And their typical action is to inhibit norepinephrine release into the bloodstream. So basically, there's receptors called alpha-2 receptors. These are the weird ones. Just you'll just have to understand this this one a bit differently. So these alpha-2 receptors live in the brainstem, and when they're stimulated by a certain drug, what are they going to do? They're going to inhibit the release of norepinephrine into the bloodstream, and they're going to cause vasodilation. So this is the only sympathetic receptor that's really weird. So when you stimulate this receptor, you kind of expect this fight or flight response in terms of increasing blood pressure and increasing heart rate. But when you stimulate this one, you get inhibition of norepinephrine release from certain nerves. So you're actually going to get vasodilation and a reduction in heart rate, because you're blocking the norepinephrine from leaving certain nerves into the bloodstream. So why would the body do this? Why would the body have an alpha-2 receptor system? Well, it's thought that because of all the other ones, the alpha-1, the beta-1, and the beta-2 being mostly very activating and causing a big rise in your heart rate and a big rise in your blood pressure, and vasoconstricting you and dilating your pupils. One of the theories is that the alpha-2 is kind of like a brake response for it. So it's because they're in the brainstem, and when they're stimulated, they actually do a bit of the opposite. They almost do what the parasympathetic system does. So it's almost like an internal brake of the sympathetic system. Okay. Unfortunately, that's just how it works. We'll come back to this again. I hope that makes sense. Okay, beta 1 receptors, again, where are they? Those are the main ones on the heart, right? And when stimulated, they increase heart rate, increase contractility. They're also on the kidneys, and when stimulated, they secrete renin. Okay. Beta 2, they're on mainly, they're mainly in the lungs, and when stimulated, they bronchodilate. Okay, to get more air in and out because you're running fast or whatever you're doing. They're on the blood vessels in the muscles, on the like the skeletal muscles, to make sure you have lots of blood going there. While all other parts are vasoconstricted, the muscles are still getting lots of blood supply to make sure that you can get away from a large animal or whatever's happening. And also they're on the uterus. They're in the uterus muscle, and it causes uterine relaxation when stimulated. Okay, so have a good idea where all these receptors live, because then whatever drug we give, you'll be able to predict what's going to happen. So if I say, well, this person's being given a beta 2 agonist, oh, okay, well, they're going to get bronchodilation in their lungs. They're going to get some uterine relaxation, and they're going to get some vasodilation in the blood vessels going to their muscles. Okay, this person's getting a beta 1 agonist. Oh, okay. Well, they're going to get increased heart rate, increased blood pressure, increased contractility, and some renin release. So just try and understand where these receptors live. Okay, so let's get to a drug here, epinephrine. So epinephrine, don't forget, is made in the body as well, in the adrenal gland, along with norepinephrine. So the sympathetic system can also stimulate the adrenal gland to release its own intrinsic or natural epinephrine and norepinephrine. But we also produce it as a drug, and we use it for certain conditions. Now, I know it says similar dopamine and norepinephrine, and they're all sympathomimetics. They're all stimulants of the sympathetic nervous system. So now we use them for slightly different things because they have slightly different receptor affinity, meaning they stimulate some receptors better than others. So we're going to take advantage of that and use the drug that stimulates the receptor that we want to stimulate. Now, epinephrine just so happens to stimulate all the receptors, alpha 1, alpha 2, beta 1, beta 2. So it's a good general sympathomimetic. And so we use it for anaphylaxis, for example, where we want to vasoconstrict all the many of the blood vessels so that we can raise the blood pressure, which is often low in anaphylaxis. It also vasoconstricts so that you get less swelling to the enlarged lips or tongue that you have, or if your airway is constricted, it'll help vasoconstrict and move some of the tissue out of the way. It helps with wheezing because it's a beta 2 agonist, so it bronchodilates. So epinephrine is the #1 drug for anaphylaxis. So if you ever get a question about someone's been stung by a bee and they have developed a swollen tongue, swollen lips, and are having difficulty breathing and they're wheezing with a rash, what's the primary drug? Well, it's not Benadryl for the itchiness, diphenhydramine. It is always going to be epinephrine. And we give epinephrine well, we never give any of these orally because they get broken down. But we give epinephrine typically for anaphylaxis as an IM shot, intramuscular shot. usually into the leg, but any large muscle. We can also use it intravenously for certain conditions, and we'll come to that. So anaphylaxis is what's the primary treatment? Epinephrine intramuscular, not subcutaneous anymore, which it used to be years ago. Okay, what about status asthmaticus? So that's someone who has a severe flare-up of their asthma that just won't improve with the normal therapies that we give. Well, we can use epinephrine for that because it's a beta-2 agonist. It bronchodilates the airways. Okay. It's often added to local anesthetics when we're trying to freeze the skin, for example. And why do we add epinephrine for that? Well, it actually vasoconstricts all the blood vessels in the tissue that you inject, so it forms a nice white blanched area, so you know exactly where you put the freezing in. And also, the freezing lasts much longer because the blood vessels have been vasoconstricted, so the local anesthetic stays in that place for longer. It doesn't get into the bloodstream as quickly. We use it for shock states like sepsis to vasoconstrict many of the blood vessels. And when we vasoconstrict, we raise the blood pressure, right? So in shock, where you often have low blood pressure, we use epinephrine. And that is often used in an IV form, very carefully. So we need to what's called titrate it. We might start slow and then go up. And that's called titrating a drug, where you titrate it up or titrate it down to get your desired effect, which in this case would be improvement in blood pressure. We can use it as a nasal decongestant because it has alpha-1 agonist effects, and there's blood vessels in the nose that are causing the congestion. So if you vasoconstrict those blood vessels in the nose with an alpha-1 agonist spray, well, that'll help with a stuffy nose. We use it in cardiac arrest. So someone who comes in receiving CPR because they don't have a rhythm, they're in ventricular fibrillation, we will give people intravenous doses of epinephrine while we do CPR, followed by defibrillation to try and get them into a cardiac rhythm. And usually epinephrine is given every 3 to 5 minutes during a cardiac arrest. Okay, so the actions we've gone over: stimulator of all 4 receptors. So now look at the adverse effects. You should be able to understand these just by the stimulation of these receptors that we may not have wanted to stimulate, but it's all part of the package deal. So anxiety, well, you've just injected a stimulant of the sympathetic nervous system. So you are going to feel anxious. You're going to have tremors, palpitations because your heart is racing, tachycardia, dizziness. Why are you going to have dizziness? This drug is awakening your whole system. It's stimulating your whole system. So you can get some dizziness with that. I wouldn't say it's one of the primary side effects. Anxiety, tremor, palpitations, tachycardia would be the main ones. And if given in high enough doses, you're definitely going to have high blood pressure from this drug. You will get stinging at the injection site with these sympathomimetics and dysrhythmias or arrhythmias, because remember, this is a direct heart stimulant. It's going to make that heart race if we give it in high enough doses. So it can cause significant. So if we misdose something like epinephrine intravenously, we can make someone's heart race very fast and put them into dangerous dysrhythmias or arrhythmias. Okay? So contraindications. So we would try to avoid it in someone who already has severe hypertension or severe coronary artery disease, because we might, well, we will cause the hypertension to be worse. We could cause their coronary artery disease we could cause it to be symptomatic and cause them to have chest pain because we're making the heart work much harder, and their heart's already diseased. Dysrhythmia, as we mentioned, if you already have a dysrhythmia, we might think twice before injecting epinephrine into you. And then closed angle glaucoma, I'll explain that at another time, but so basically epinephrine will dilate your eye. And if you have a certain type of glaucoma, I won't do it on this slide, if you have a certain type of glaucoma, it can aggravate that glaucoma and cause the pressure in your eye to go very, very high. So I will get to that on another slide. So cannot be used orally because it'll be broken down. So administered IM or IV, and sometimes inhalation. And we don't use it subcutaneously anymore because it wasn't well absorbed. Okay, so multiple uses for epinephrine. Probably the most common one you're going to see it in is anaphylaxis, but it's totally appropriate for all of those indications. Hopefully the adverse effects now make sense to you. By stimulating all those different receptors, you also get those adverse effects. Okay, so here's epinephrine in an auto-injector. So this is what people are getting when they have allergies. So an anaphylactic reaction to a certain food or to a bee sting or a wasp sting. So you would carry this around with you everywhere you go. And this one, EpiPen 2, so this comes 2 in a pack. So it's always nice to have one, say, at your house and one, on you. And so remember the 2 ways. So if you're given an EpiPen, like epinephrine, to be administered by yourself or by someone else that's with you, it would always be an IM shot. You would never try and get an IV. In the hospital, for anaphylaxis, we would use it as an IM shot, but if it wasn't working well enough, well, we'd repeat the IM shot, but sometimes we have to go to IV epinephrine. And that's a whole different level of complexity, intravenous epinephrine. It takes very careful dosing. So these auto-injectors are very easy to use. There's videos on it. You basically, it has a spring-loaded needle. You basically just directly inject it into your thigh muscle, and it will inject the epinephrine into the muscle, and then which will make it into your bloodstream. And remember, you'll probably learn anaphylaxis in pathophysiology, but whether you learn it there or a bit here, remember anaphylaxis is a systemic reaction to some kind of allergen, whether it's a peanut or a wasp sting or a food, and it's caused your system to release a whole bunch of inflammatory markers, and it's caused you to have a diffuse body rash, which isn't really concerning, the body rash. But what is concerning is when you run into airway issues with a swollen tongue, swollen lips, closing airway, your larynx is closing, respiratory, bronchoconstriction, wheezing, short of breath, the cardiovascular system, hypotensive, tachycardic, and the gastrointestinal system people forget about, where you have vomiting after eating. So that can be included in an anaphylactic reaction, where you have vomiting immediately after eating a certain food or whatever you were allergic to, you vomit. So people that are allergic to peanuts, if they happen to eat a peanut, they often, as part of the anaphylactic reaction, they vomit with it. Okay, so remember all those different aspects. So it's the skin, it's the cardiovascular system, it's the respiratory system, and it's the gastrointestinal system. And you just need two systems to call it anaphylaxis. So it could be a diffuse skin rash plus the vomiting, or it could be a diffuse skin rash with a swollen lip and tongue, or it could be a diffuse skin rash with shortness of breath and wheezing. Okay, so I think you'll learn a bit more about anaphylaxis and pathophysiology. But that is definitely one of the main reasons to use epinephrine. Okay, just because it stimulates all the sympathetic receptors, the adrenergic receptors. Okay, well, what about norepinephrine? Well, it's very similar to epinephrine. It's slightly different in structure, and we don't need to get into that. But there's a tiny difference in structure. But this has preferential affinity for the alpha-1 receptor. So all you need to know is where the alpha-1 receptors are. And then you're going to say, well, they're on the blood vessels. They're on the blood vessels that will be vasoconstricted. They will be tightened and closed preferentially by norepinephrine. So if I asked you, well, will norepinephrine stimulate the heart? You'll say, no, not really. There's no beta-1 activity really of norepinephrine. It's mostly alpha-1. So if we really want to get someone's blood pressure up, say in sepsis or in some kind of shock state, we could use norepinephrine. And people in intensive cares are often on norepinephrine to maintain their blood pressure in the setting of severe hypotension due to a variety of medical conditions. Okay? And it's all because of this being very specific to alpha-1 receptors causing the vasoconstriction. Look at the side effects, identical to epinephrine, because it's a very similar drug. So it's going to give you the anxiety and the tremor and the palpitations because you're turning on the sympathetic system, okay? Stinging at the injection site. And I didn't mention this, but any of these drugs, if they get out of the IV and make it into the local tissue, I think we spoke about this in chemotherapy. This is slightly different with these drugs, but if it was to extravasate into the local tissue because the IV came out, that's going to cause intense vasoconstriction. So they're going to tighten up all the blood vessels locally in the tissue. They're going to vasoconstrict them so that there's no blood supply. So you can get, you have to keep a very good eye out for these IV sites because you'll get vasoconstriction of the tissue where it's leaking out, and you can get necrosis, meaning death of that tissue because of the powerful vasoconstriction. Okay, hypertension, dysrhythmias, that was just like epinephrine. The contraindications, very similar. Sure, it's going to get your blood pressure high. Is it going to make your heart work harder? Sure, so might want to think twice in coronary artery disease. Why is it going to make your heart work harder? Because you're really raising the blood pressure. Why is it going to give you some dysrhythmias? Well, don't forget that we're saying that it has mostly alpha-1 agonist activity, but there's always a bit of overlap between these. It's not totally cut and dry, so this might have 90% alpha-1 agonist activity, but it could have a bit of beta-1, or I wouldn't remember that part. I'm just saying that's why you could have some dysrhythmias with it, okay? Nursing responsibilities cannot be used orally, okay, because it'll be broken down, and it's really an IV only drug. So it's really an emergency room / ICU type drug. So what about this closed angle glaucoma? Let's get to that. So in glaucoma, if you have a history of glaucoma, if I cause your pupil to dilate, the iris, which is the tissue that's being dilated and making your pupil very large, will bunch up against the side wall of the eyeball. And when your iris bunches up there, it can block the drainage of the intraocular fluid to where it's supposed to drain out and get back into the circulation. So if you have a history of what's called closed angle glaucoma, and we give you drugs that can dilate your eye, we could bring on a severe episode of severe closed angle glaucoma. Okay, so I'll just say that there. I will go into it and mention it again on another slide. Okay, so dopamine and dobutamine. Well, look. So just know which receptor does it stimulate. Well, these typically stimulate beta 1. Okay, where's beta 1? It's in the heart. So if you stimulate the heart, you're going to make it beat faster and harder. And it also stimulates alpha 1 a bit as well. So you'll raise the blood pressure because you're vasoconstricting. Okay, so it's used for short-term treatment of shock related to heart failure due to its ability to cause the heart to beat faster and more forcefully. Okay, so because it's stimulating the beta 1 receptor, it's telling the heart beat faster and beat harder. And that's exactly what, so in someone with, say, heart failure, where the heart just isn't pumping very hard anymore, we could use dopamine as a short-term treatment. It's always intravenous, to try and just get that heart to beat harder for a while and beat a bit faster to maintain cardiac output. Okay? Look at the side effects or the adverse effects. They're all the same as any other sympathomimetic. Okay, so dopamine, we wouldn't use that in someone who has sepsis and we want to just vasoconstrict their blood vessels peripherally. No, we would use norepinephrine for that because the underlying problem is vasodilation from the sepsis. Dopamine is going to force the heart to beat harder and faster. So if you have a weak, floppy heart from heart failure, so it's a weak muscle heart, we could use dopamine to try and stimulate it to beat harder and faster. Okay, so phenylephrine, okay, just another sympathomimetic. And what do we use this for? Well, we're going to take advantage of the fact that, so we always ask ourselves, which receptor does it work best? So, having studied all these drugs in the lab for decades, we know which receptors they like the most. So phenylephrine is very similar to norepinephrine. It likes alpha 1. Okay, where's alpha 1? On the blood vessels. Okay, so if I give you an injection intravenously of phenylephrine, it's going to vasoconstrict your blood vessels and raise your blood pressure. So we could use phenylephrine for low blood pressure, for acute hypotension. Okay, so now we have 2 drugs that we could use for that if we really wanted to get someone's blood pressure up in the setting of sepsis or some kind of shock state. And it's very easy to use. You just give it as an injection. So norepinephrine or phenylephrine, they do very similar things, but we do use it for that. But something that's more commonly used in is nasal congestion. So you have blood vessels in the tissue of your nose, and when you have allergies, such as in allergic rhinitis, so allergic rhinitis is nose, so inflammation of the nose due to allergies. How can we help someone who's always nasally congested? Well, we can put phenylephrine or some kind of similar compound like oxymetazoline or pseudoephedrine in a nasal spray or in a tablet for you to take by mouth, but often in a nasal spray that you can spray into your nose, or you can take as a pill to then help with vasoconstricting in your nose, so the tissue shrinks and you can breathe better. Okay, and you can use that in the eye too. So say you have very red eyes, say you had a late night or a long weekend, and you have very red eyes and you're going to work, and you want to use something like Visine. Well, there's nothing really fancy in Visine. It just has one of these compounds that's going to vasoconstrict the blood vessels and take the redness out of your eyes. Okay, so if you have a drippy nose from allergies, you not only can you use allergy medications like antihistamines, but you can use a decongestant, a nasal decongestant to vasoconstrict all those leaky blood vessels that are causing the runny nose, and help with your breathing through your nose. Okay. So what are the adverse effects? Well, sure, you could get local irritation when you're spraying it in your nose, sneezing from the nasal spray, fair enough. Rebound nasal congestion. So if you use this for more than 3 to 5 days, when you stop using it, the blood vessels are going to open up. They're going to vasodilate even more, and you'll have more nasal congestion. So it's strongly recommended not to use this for beyond 5 days. You almost become a bit addicted to it. So yeah, it's not an addiction, but the blood vessels in your nose can become used to having it around, and when it's not around, they vasodilate, and you get more congestion, called rebound nasal congestion. And if you take enough of it, either as a nasal spray or definitely by mouth, you're going to have stimulation of your central nervous system. So tremors, anxiety, insomnia. Okay, so look at the contraindications. Very similar again. So on the box, if you look at any one of these, whether you're buying it in the pill form or if you're buying it as a nasal spray, on the package it's going to say, don't use if you have hypertension, angina, coronary artery disease, because you're going to make the heart work harder with tachycardia from this drug, or narrow angle glaucoma. It'll probably just say glaucoma, because you could worsen your glaucoma with this, because it'll dilate the pupil, right? So these are the contraindications, and the adverse effects are still from, a lot of them are from stimulation of receptors, but you're accepting those effects because you're also stimulating the alpha-1 receptors in the nose, which is what you want. That's the effect that you want. Okay, so nursing responsibilities. Typically, advice would be not to use this for beyond 3 to 5 days due to rebound congestion, and it can be really hard to get off this medication when your nose is now used to it. Okay. Okay, so we won't spend too much time on this medication, isoproterenol. This is an intravenous drug. It would be used similar to dopamine for cardiogenic shock, so heart failure. Your heart is basically not pumping very much blood at all. Or if you want to get the heart to beat harder and faster because you're in a very, very slow rhythm, such as 3rd-degree heart block, because it's going to stimulate the heart. So remember, it's a beta 1 and beta-2 agonists. So the beta-1 activity is it's going to make the heart beat harder and faster, which is what you would want if your heart was failing or if it was beating extremely slowly, such as in a third-degree heart block. Okay. Adams-Stokes syndrome, an arrhythmia causing cardiac asynchrony leading to decreased cardiac output and loss of consciousness. So this is a condition where intermittently your heart loses its cardiac output because of an arrhythmia, a short-lived arrhythmia. So your cardiac output is, remember, your heart rate times your stroke volume. Okay. So this drug can be used to maintain stimulation to the heart because it's a beta-1 adrenergic agonist. I wouldn't spend too much time on Adams-Stokes syndrome. You could look it up if you want to. I think the general concept is isoproterenol is used to in a shock-like state, usually from heart failure, where you're getting the heart to beat faster and harder, or in a very, very slow heart rate from something like a heart block, where this drug is just going to directly force the heart to beat faster. Adverse effects going to be the same as all the other sympathomimetics. Contraindications are going to be all the same. Okay, glaucoma is not there, but it'll be a contraindication as well. Nursing responsibility. So when we use a drug that's trying to pump more blood out of the heart, you always want to make sure that the person's not dehydrated, that they have proper volume in their circulating system, right? In the arteries and the veins, that they're not, say, dehydrated. Because, you know, say we're treating someone who has low blood pressure, there's no sense in forcing the heart to beat faster and harder if they don't have enough blood volume in the whole system. So we always make sure that they have proper blood in the whole system that can be pumped before we actually use a pressor agent. So now remember, so if the main action of the drug is to stimulate the heart to beat faster and harder, it's called an inotrope. If the main action is for it to vasoconstrict the periphery and to raise blood pressure by clamping down all the blood vessels in all the different capillary beds, that would be called a vasopressor. Okay, so if you hear the word an inotrope, you know, can you please get me this inotrope? Well, that would be something like dopamine or isoproterenol. Can we get a norepinephrine drip going? That's a vasopressor. Okay, and this is the same concept that we were just talking about, filling the tank. So you want to fill the circulation, the systemic circulation, with blood volume prior to using either a vasopressor or an inotrope drug. So say, for example, that you went on a marathon and you came in and it was a very hot day and you've lost liters of fluid from sweating, and you come in and you're confused and your blood pressure is, say, 80 on 40 and your heart rate's 130. Well, we're not going to give you isoproterenol or norepinephrine or phenylephrine. We're going to give you fluids, intravenous fluids, to fill your blood volume back up. And then if you're still hypotensive and we think something else is going on, then we may use a vasopressor or an inotrope drug to help with the blood pressure or to help with the cardiac contractility. So we always make sure that you're properly fluid hydrated before using these drugs. Okay, so let's talk about, let's use an example here of a sympathomimetic. And we'll use albuterol. So albuterol is an inhaler that's used for asthma or COPD. And it's a short-acting beta-2 agonist. So to go back to the slide about beta-2 agonists, what's one of its primary actions? It bronchodilates. Okay, so there's beta-2 receptors in the lung, on the bronchial tubes, and when stimulated, they bronchodilate the bronchial tubes. So albuterol happens to be a short-acting one. It doesn't last very long, but if you have a flare-up, you can always take more albuterol to bronchodilate your bronchial tubes. There's some other ones. So when you see SABA, that is short-acting beta agonist versus a long-acting beta agonist. And we'll get into this more when we do respiratory drugs. So short-acting beta agonists are to relieve bronchospasm. So they're considered a rescue inhaler. A long-acting beta agonist in an inhaler is for long-term control over the whole day. Okay, so they would never be used as a rescue medication. And a rescue meaning I'm short of breath right now, I need something to help my wheezing. Okay? So rescue medications are beta-2 agonists. And try not to confuse. I mean, look at one is salbutamol, and there's one salmeterol, and they're different, right? Now, don't forget, because it primarily stimulates the beta-2 receptors, it's mainly going to have effects in the lung, especially since it's an inhaler. But where else are beta-2 receptors? Well, they're on the uterus. So we could use this to try and stop preterm labor. They're on blood vessels. So if taken in huge amounts, they might have an effect on the blood vessels. You don't typically take that much. But I want you to have the concept that we call it a beta-2 agonist, but if given in high enough doses, it's also going to stimulate the beta-1 receptors. Not that you need to memorize that, but it will help you understand the side effects when you say, well, it's not just beta-2. It has a bit of effects on the other ones too. And that will help you with the side effects. So anyways, we use it for relief of bronchospasm in asthma and chronic obstructive pulmonary disease. Or if you know you're going to exert yourself, such as in exercise-induced asthma, you're going to exert yourself, then you would take 2 or 3 puffs prior to the activity, and that would prevent the wheezing from coming on. We also use it in protocolized treatments for hyperkalemia, and you'll learn about that in pathophysiology, how albuterol, when given by mask, can lower serum potassium. Okay. So adverse effects, well, they're very predictable if it's a sympathomimetic. Palpitations, sure, it's going to increase your heart rate a bit, okay? And that's going to be its beta-1 effect, which is starting to occur if taken in large enough doses. But remember, it's always going to be considered a beta-2 agonist, but nothing is 100%. Okay, headache and throat irritation. Okay, I wouldn't get too much into that. Tremors. Sure, because it's a sympathomimetic. It can give you tremors. It can make you nervous. Tachycardia. Insomnia. Yep, it's a stimulant. It's in the sympathomimetic group, right? It's an adrenergic agonist. Dry mouth. Sure. Remember, the sympathetic system tends to dry out your mouth. And hypokalemia, if given in large amounts as an inhaler, because it drives potassium into the cells. And again, you'll learn about that in pathophysiology. Contraindications. Well, if you already have a racing heart, like a tachydysrhythmia, we may avoid giving you albuterol. If you have coronary artery disease or angina, we're going to make the heart race a bit faster. That might put more stress on the heart. And hypertension, we might avoid it in hypertension, especially if you're on large doses or very frequent dosing of it. So what kind of the nursing responsibilities? So people with asthma often have a sensitivity to aspirin. So we often advise asthmatics to not take aspirin products, so ASA and NSAIDs. And as well, if they're asthmatic, not to take beta blockers. So there's beta agonists like albuterol, but we're going to talk about beta blockers or beta antagonists. And if you're taking beta blockers, not only is that going to stop the effect of the albuterol, but that could give you more wheezing and more shortness of breath if you're asthmatic or if you have COPD, because it's blocking that beta receptor in the lungs and sympathomimetics, your epinephrine, your norepinephrine, or this inhaler such as albuterol can't stimulate the beta receptor. Anyways, we'll come back to that. What about the drug administration? So if you're on multiple inhalers for asthma, it's the first one you typically take is the beta-2 agonist, the short-acting beta-2 agonist, such as albuterol, because it's going to immediately bronchodilate. And that allows other inhalers, other medications, to get deposited deeper into the lung. So if you're on a cortisone inhaler, for example, it'll deposit deeper into the lung tissue if you use the albuterol first. And often we use spacers for these inhalers. They're very hard to time. An albuterol inhaler on your mouth is hard to time when you're pressing it and then taking a deep breath and inhaling it. So we use aero chambers, they're called, and we'll come back to that, what an aero chamber is. What else is there? I think that's it for this slide. So albuterol, beta-2 agonist, used in asthma and COPD, can give you any of those sympathomimetic adverse effects. Okay, so we just spoke about a beta-2 agonist, albuterol, and again, mainly used for its bronchodilation effect, and sometimes in preterm labor because it relaxes the uterus, since there's beta receptors on the uterus. And we'll come back to these. Just get the understanding of these receptors first. So let's talk about some alpha receptors. So remember, for whether it's alpha or a beta receptor, you can have something that can stimulate it, or you can have something that can block it. Okay, so you're going to hear alpha agonists, alpha antagonists, beta blockers, beta agonists. So those are the four groups. Okay, so we're going to talk about a drug that's been around for a long time, over 40 years. It's called clonidine, and it was initially marketed as a blood pressure medication. And now it has a lot of indications, but I'm going to tell you we don't use it very much for blood pressure anymore because of all its side effects. And we have much more effective blood pressure medications. And I'll get to some other reasons why we use it, but it's not an overly safe medication. So in general, you won't see clonidine very often being prescribed. Now, the other thing I want you to remember is there's really this alpha agonist. So we're going to talk about alpha 2 agonists. Okay. Uh, Now we did mention alpha 1 agonists. Remember, the alpha 1 receptors was mainly on the blood vessels. So if we stimulated the alpha 1 with norepinephrine or phenylephrine, we had powerful vasoconstriction, which helped keep the blood pressure up because it's stopping the blood from flowing towards all the different capillary beds. So that was an alpha 1 agonist. We're going to talk a bit about alpha 2 agonists. And clonidine, and there's another one called methyldopa. They're very old drugs. Still see them on ATI and NCLEX. So I think for that reason you do have to know a bit about them. But they're really the only two alpha 2 agonists out there. And again, very old medications. So let's look at clonidine, and the other one I mentioned is methyldopa, and they were both marketed many years ago, before most of us were born, as blood pressure pills. And so where are the alpha 2 receptors? Always ask where the receptor is, and you'll know what the effect will be. So remember, the alpha 2 receptors are in the brain stem, and when stimulated, they do this weird thing of basically down-regulating the sympathetic system. So it's a sympathetic system receptor, alpha 2 receptor, but it inhibits release of norepinephrine when stimulated. And we spoke about that as kind of being the internal brake. So when stimulated, it decreases sympathetic outflow, which years ago it was felt, well, that's a way of dropping blood pressure, right? So you decrease the sympathetic outflow, and that's going to drop blood pressure because you have less norepinephrine vasoconstricting the blood vessels. Okay. So the indication for many years was hypertension. And it still could be used for hypertension, but it would be extremely unusual nowadays with all the different other blood pressure medications that we have to see this frequently used. And because this drug's been around for a long time and it works in the brain stem, so that's where also its side effects are going to come from. But that's where the other indications kind of started to be discovered while people were on it for hypertension. We noticed that it helped with alcohol withdrawal. It helped with opioid, narcotic withdrawals. So it's used for that. So if someone is withdrawing from narcotics, we can use clonidine to help with those symptoms. And it was used for years in children with attention deficit hyperactivity disorder. There's other drugs that are now available for that, so it's much less frequently used for that, just because of its poor safety profile. Okay, so let's look at the adverse effects. Well, if it works on the brain, think of brain side effects. So look at the effects: drowsiness, sedation, dry mouth. The dry mouth is quite common with clonidine. Rebound hypertension. So if you were to stop this drug, suddenly you'd get an outpouring of norepinephrine because you were inhibiting it with the drug, and you'll suddenly get you will get a rebound hypertension if you stop it abruptly. So most of the time we advise people that are on antihypertensives, and this one is considered an antihypertensive, old one, not to ever stop them abruptly. Okay. So typically this drug would be tapered, would be gradually reduced if the plan was to stop it over the span of 2 to 5 days, not to suddenly just discontinue it. Okay. Uh, with this medication, there's a chance of drowsiness and sedation. So driving, advice on being careful driving or operating heavy machinery can be suggested to the patient on this medication. Taking, sipping fluids or sucking on a candy to help, or ice chips to help with the dry mouth, because they can definitely get dry mouth with this. So that would be advice for someone who's taking clonidine. So other things to consider with this drug is advising the patient that they can become dizzy, lightheaded, and very faint with this medication. It can drop their blood pressure precipitously. And if that were to happen, then they would need to lie down as opposed to just collapsing because the blood pressure is dropping. And also to change positions from lying down to sitting up and then standing up slowly, because when you go from lying down to standing up quickly, you can have an orthostatic blood pressure drop, right, from lying down to standing. And also to be careful with this drug when taking other sedatives, because this drug has sedative effects. So alcohol, benzodiazepines can aggravate the sedation when on this medication. So you can see that this is not a fantastic pill, and it's a dangerous pill. It can take 1 or 2 pills to kill a child. So having this in the house is not the best drug, not the safest drug to have. And how can it kill? Well, they can get severe hypotension if taking this medication. So we've gone away from this medication due to safety concerns. Okay. Okay, so you'll be glad to know that there's really no such thing as an alpha-2 blocker. Okay. We did talk about an alpha-2 agonist on the previous slide, the clonidine and methyl-dopa, which just basically consider them, they do the same thing. They're alpha-2 agonists. But because the alpha-2 receptors are in the brain, we just try not to play with them as much. So there's really no alpha-2 antagonist. So if you look here, there's alpha-1 antagonists, there's beta-1 antagonists, and there's beta-2 antagonists. Okay, so these are the adrenergic antagonists. So just think of where the receptors are, and that's the action it's going to have. So let's look at the alpha-1 receptors. Where are they? Blood vessels in particular, and there's some alpha-1 receptors on the valve that opens and closes the bladder going into the urethra. So just in the upper prostate. Okay. So what would be some indications we could use is if we can block the alpha-1 receptor on the blood vessels, well, then they're going to vasodilate because they're not being vasoconstricted by norepinephrine anymore. So that would help with hypertension because we're vasodilating, we're opening the blood vessels. Okay, so blood pressure medications will fall into this, will definitely be in this group. What about benign prostatic hyperplasia? So a male that has a large prostate and it's very difficult to empty his bladder. And it's partly because of the valve at the top of the prostate. So that valve tightens and closes even more if it's stimulated by an alpha agonist. Okay, so we don't want to do that. But what if we use an alpha antagonist, an alpha 1 antagonist? Well, that's going to open up that valve a bit and help urination in a male with BPH, benign prostatic hyperplasia. So you can see that we could use them there to help urine flow. And the last one is Raynaud's disease, which is it's more often in females, but it can happen in anyone. And it's often in the cold weather where you get vasoconstriction of the little arteries in your digits and your fingers and toes. So by blocking the alpha 1 receptors, we're getting some vasodilation that can be helpful in people with Raynaud's disorder or Raynaud's disease. Okay, so that's the alpha 1 antagonist to block that alpha 1 receptor. What about the beta 1 receptors? What if we block those? Okay, where are the beta 1 receptors mainly? They're in the heart. Okay, so they're in the heart muscle. They're part of the electrical conduction system. So it's going to, if you block beta 1 receptors from being stimulated with certain drugs, then you're going to do what? You're going to reduce the contractility of the heart. So that's reducing inotropy of the heart. You're going to reduce the heart rate. So that's reducing chronotropy. And you're going to slow cardiac electrical conduction. You're going to slow dromatropy. Okay, why would we do that? Well, these drugs will slow down the heart and reduce contractility. So basically, they're going to reduce the workload that the heart is doing. It's not working as hard anymore. So that can help someone with angina. An angina is where you have some blockages in the arteries that feed the heart, and they're fixed blockages. So if you can reduce the workload of the heart, then you don't need as much blood flow. Then you don't get anginal chest pain symptoms. So you haven't changed the blockages, but what you have changed is the amount of work that the heart's doing, like reducing it, so it doesn't need as much blood flow. We also use these in heart failure, and we'll definitely come to that. We definitely use these in hypertension and high blood pressure because it slows down the heart and it reduces contractility. That's going to reduce cardiac output. It's going to help lower the blood pressure. And we use these in people having sustained a heart attack and as a treatment after a heart attack because they can rest the heart. Reduced contractions and reduced heart rate, the heart's not working as hard after a heart attack. Okay, what about the beta 2 receptors? If we antagonize them, meaning if we block them. So beta 2 antagonists. Well, I have some good news for you here. We would not use these drugs very often. Look at the effects of these drugs. Bronchoconstriction. When would we want to tighten someone's bronchial tubes, to narrow them? Not very often. Look at the next effect of blocking the beta 2 receptor. Increased intestinal motility. So because you're blocking the sympathetic flow to the gastrointestinal tract, then you in fact are allowing the parasympathetic system to work more on the gastrointestinal tract, and that typically causes more peristalsis, more secretions. But why would we do that? We wouldn't do that with a beta 2 receptor antagonist. And then uterine contractions. So a beta 2 antagonist because you're blocking the beta 2 receptors on the uterus, then there's the potential to cause the uterus to contract, because remember, the beta 2 agonists, such as albuterol, cause the uterus to relax. So we may talk about this a bit, but I wouldn't get too there's not going to be many drugs in that group at all. So the drugs in terms of the antagonists on the sympathetic side, it's going to be alpha-1, and we'll get to them, and beta-1 antagonists mainly. Okay, and I told you there are no alpha-2 antagonists at all. Okay, this slide looks painful, but it's just I would ignore the drugs at the bottom. You would not need to know all these drugs. Only the drug endings are nice to know. So if you look at Olol, okay, that's a beta blocker. If you look at Osin, OSIN, okay, that's an alpha blocker, and you'll get to know that over time just by seeing the ending. So we're talking at the top here about adrenergic antagonists, okay? And we've already learned that you have alpha receptors and beta receptors. So let's go to the left here. Alpha antagonists. Okay, so forget about alpha antagonists, yohimbine. We used to use it for erectile dysfunction. It's not used anymore. I don't think you even have to look at that box. Look at the alpha-1 antagonists. Remember, they block. They're going to cause vasodilation and open up the prostate valve a bit. So because just ask yourself where the alpha-1 receptor is. It's on blood vessels and the prostatic valve. So most of these are blood pressure pills. Prazosin, terazosin, doxazosin, those are blood pressure pills. But some of them can be used for the prostatic valve, and it just depends on how they're marketed. So tamsulosin, for example, the brand name for that is Flomax. So Flomax, you can just imagine what that's for. That's to help the flow in benign prostatic hypertrophy, to relax that valve at the top of the prostate in men. So we'll come to these. I don't think you need to memorize, just understand where the receptors are, okay? Now, the non-selective alpha antagonists, we will mention that in the future. They're not very important at all. There will be so the only one in that group that you would need to know anything about is phentolamine. And we use that if we're giving someone, say, an epinephrine or a norepinephrine intravenous drip. And so those are, and it leaks into the tissue all in the arm where the IV was. Okay, so norepinephrine is a very powerful alpha-1 agonist. So we're going to try and stop it from really vasoconstricting all those little tiny capillaries in the tissue by giving phentolamine, which is an alpha antagonist. So we're going to try and limit the tissue damage caused by the norepinephrine by giving phentolamine. Okay, let's go to the other side. Beta antagonists. So beta antagonists are basically beta blockers. That's it. It's a whole bunch of them, but they're just beta blockers. Okay, and it just depends on whether are they selective to the beta-1 receptor. And where's the beta-1 receptor typically? It's in the heart. So if they're selective to the beta-1, then they won't mess around with the beta-2 receptor that's typically in the lung. Well, that's fantastic. I don't want you to block my beta 2 receptor because that's going to cause wheezing and shortness of breath in someone with COPD and asthma. So beta 1 selective, I would prefer to use, okay? Because then I don't have to think of the wheezing and shortness of breath they can get because I'm blocking their beta 2 receptor, okay? Non-selective just means that it blocks the beta 1 receptor and the beta 2 receptor. And we'll talk more about this. But basically, when you're blocking the beta 1 receptor in the heart, you're using it for, as we mentioned before, angina, for hypertension, for heart failure, and you're not having to worry about blocking the beta 2 receptor. Okay, but we'll come back to these, or to some of these anyways. You don't need to know all these drugs. Okay, so let's look at prazosin. Remember the ending, right? So prazosin is an alpha-1 blocker. Okay, so it's like doxazosin. Phentolamine, I would just ignore there. That's we don't use it very often, except for in that one circumstance I told you where you have leakage of norepinephrine or epinephrine into the tissues. So doxazosin and terazosin are also antihypertensive, so blood pressure, reducing blood pressure. Prazosin, doxazosin, terazosin. Now, there's some that have been marketed for BPH. They're still in the same group. They can still lower your blood pressure, but they've been marketed more for benign prostatic hypertrophy. And that would be tamsulosin, which is Flomax. Now, would it be wrong to give terazosin for someone who has BPH? No, you could use terazosin for someone who has BPH. It's in the same group, right? And you could also use it for someone who has hypertension. So that's perfect. If you have difficulty urinating because of your prostate and you have high blood pressure, well, this drug might be the one for you because it's going to help you urinate better if you're a male, and it's going to hopefully lower your blood pressure. Okay, so look at the indications. Hypertension, okay. Symptomatic BPH, meaning I'm not able to fully empty my bladder. I'm having to get up 3 or 4 times a night to pee because I can't empty my bladder. Raynaud's disease we spoke about. That's of the hands and the feet, where they turn bluish and then pale because of the vasoconstriction of the blood vessels in the fingers, especially in the cold. Sleep disturbance, nightmares related to PTSD. That would be a very rare indication. The main one for this is high blood pressure and BPH. Okay, and what is it? The actions is an alpha-1 receptor blocker. Adverse effects. Well, think about what it's doing or where it's acting, and you'll probably be able to predict the adverse effects. So could it make you dizzy? Absolutely. It's going to drop your blood pressure. It could make you dizzy from having lower blood pressure. Okay. Can it make you drowsy or fatigued? Yes, it can, and that can be a function of lowered blood pressure as well. Okay. Can it give you orthostatic blood pressure changes, meaning when you're lying down and you get up too fast, your blood pressure drops significantly. And orthostatic blood pressure is usually defined as from lying down to standing. If your systolic blood pressure drops by 20 or greater, or if your diastolic blood pressure drops by 10 or greater, then you have orthostatic changes, okay? But we also base it on the person's symptoms. It's like, oh, when I get up from lying down, I'm extremely dizzy and I feel like I'm going to fall over. Ooh, okay. That's concerning for orthostatic symptoms. First dose phenomenon is, and this is why we initially give this medication at bedtime, because you're lying down and sleeping. So even if it causes a first dose significant effect of lowering your blood pressure, you're lying down and sleeping. So first dose phenomenon can happen in any blood pressure medications, but in particular, it can happen in this group. And what happens is the body is not accustomed to this drug at all, and it suddenly blocks the alpha-1 receptors, and you can get precipitous drops in blood pressure, okay, for the first dose. So that's why the first dose is given at nighttime, and then you can switch it over to daytime dosing once the body gets used to it. Reflex tachycardia at the beginning. Why would you get reflex tachycardia? Well, you're vasodilating the blood vessels. So what does the heart say? So you're lowering blood pressure by vasodilating the blood vessel. The heart says, I'm noticing the blood pressure is dropping. I better beat faster. So you can get a reflex tachycardia at the beginning of using this medication. Contraindications, well, elderly, yes, because you can make them fall with these medications. We still use them, we're just careful in the elderly. But if you give an older person an alpha-1 blocker and make their blood pressure drop precipitously and they fall and break their hip or do something else, then it's definitely a risk. Renal impairment, just because it's excreted renally. And coronary artery disease, essentially just because of the reflex tachycardia that you can cause. So if someone has angina and they're older, it wouldn't be a great drug because you're making their heart beat faster initially, and you're making their blood pressure potentially drop precipitously with the first few doses. So it'd be a bit dangerous. So nursing responsibilities, definitely monitoring the heart rate and the blood pressure, advising them on these orthostatic symptoms that can occur by getting up too quickly. So sit on the side of the bed for a minute or two before you stand up, and then stand up carefully and see if you're dizzy. We start with low doses and then go up slowly on the dose. The first dose is given at bedtime. And often we will combine a medication such as a beta blocker with an alpha-1 blocker for blood pressure. And why would we do that? Well, if we can vasodilate the blood vessels with an alpha-1 blocker, such as prazosin or terazosin, I mentioned that the heart will speed up to try and compensate for the vasodilation and the lowering blood pressure. But if we use a beta-1 blocker, then we'll stop the heart from speeding up. So we're addressing two causes of the hypertension, and we might be able to control it better. So we went over this already, first dose phenomenon. So a sudden and severe decrease in blood pressure with the first dosing of a medication, typically a blood pressure medication, often an alpha-1 blocker. It can be with other blood pressure medications as well. Syncope is loss of consciousness that then resolves and you return back to baseline. That's called syncope. Give the first dose at bedtime to prevent falls and subsequent injury. Well, that's exactly what we do with alpha-1 blockers. Once your patient has adjusted to the medication, usually the first or second follow-up visit, the HCP will transition your patient to daytime dosing. Yes, we can, because hypertension is typically higher during the daytime, then we can move this nighttime dosing to a morning dose once we know that this first dose phenomenon isn't continuing or isn't an issue. Okay, so that's the concept of first dose phenomenon with blood pressure pills. So let's talk about propranolol, which is a non-selective beta blocker. And so anything that ends in olol typically is a beta blocker, okay, or alol, olol. They're all beta blockers. You just have to distinguish the prototypes between non-selective and selective, and sometimes even in questions you're told selective beta blocker, non-selective beta blocker. So this is one of the oldest beta blockers, and it was originally produced for treatment of hypertension, since it blocks the beta-1 receptor in the heart and reduces contractility and heart rate. It was also used for angina because it reduces the workload of the heart, as we discussed before with beta blockers. Fast heart rates, dysrhythmias, we can slow it down with a beta blocker because that's what they do in the heart. And also, it over the years it got an indication for migraine headaches because we noticed people that were taking this that had a history of migraine headaches had improved symptoms and less migraine attacks. So propranolol is used on a daily basis to prevent migraine headaches, not to treat them acutely, but to prevent them. So the action we already mentioned. The adverse effects, you can get nausea, vomiting, and diarrhea with beta blockers. And why is that? So if you're blocking the sympathetic system to the gastrointestinal tract, you're actually allowing the parasympathetic to work more. So that's stimulating the bowel. So you are going to get nausea and vomiting and diarrhea because you're allowing the parasympathetic system to have more effect on the gastrointestinal tract. Bradycardia, well, we know that because it slows down the heart. It's a beta-1 blocker, it's a beta blocker, beta-1 and beta-2. And beta blockers in general, remember this one, fatigue. Profound fatigue. People often come back a week later and say, I can't take this drug. I'm exhausted all the time. Okay? So that's a very common side effect of beta blockers. What about the contraindications? Well, if you already have low blood pressure or you already have a low heart rate, so say your heart rate is 50 or below, well, you're not going to start a beta blocker. It's going to lower it even further. Or someone who has heart block, meaning the conduction of the electricity in the heart, that we will go into further detail in other classes, is affected, and they typically have very slow heart rates to begin with. This will slow them down even further. So beta blockers, including propranolol, are contraindicated in heart blocks or very slow heart rates. Moderate heart failure. So this will be confusing for beta blockers because we do use beta blockers in some patients with heart failure, and then we don't use it in others, and it just depends on the degree of the heart failure. Okay, some people with severe heart failure, we will use small doses of beta blockers, and then in other patients we don't use beta blockers in heart failure. So that can be a bit confusing. Obstructive airway disease. So here's where the difficulty comes in. You want to use this medication, this non-selective beta blocker, for blood pressure control or to slow down the heart. Oh, do they have COPD? Do they have a history of asthma? Because it will make it worse, right? Because it's blocking the beta-2 receptors as well. Nursing responsibilities, to remind yourself of the cardiac rules. We'll come to that shortly. Masks shock. So it can hide the potential of someone who's going into shock. And why does it do that? Well, if you're taking a beta blocker and say you're bleeding, and you're bleeding profusely from somewhere, say a gastrointestinal bleed, and your blood pressure's dropping, it's your sympathetic system that's going to help increase your heart rate and vasoconstrict your blood vessels to maintain your blood pressure. Well, if you're on beta blockers, that's going to block the norepinephrine from your sympathetic system from speeding up your heart or vasoconstricting your blood vessels. But in particular, it'll stop the norepinephrine from speeding up your heart and increasing contractility. So you could have someone who's in shock but has a heart rate of 90 because the beta blocker is blocking the norepinephrine from speeding up the heart. And in diabetics, so a diabetic that's on insulin, not on pills, but typically on insulin, or actually there is one group of medications orally called glyburide. I think we'll come to that, that can lower your blood sugar. Metformin can never cause you to be hypoglycemic, but glyburide or glipizide can. So it's typically people with taking insulin or glyburide where their sugars can go too low. Well, what system is responsible for being alerted that your sugars are going too low? It's the sympathetic system, right? So when your sugars go too low, your sympathetic system alerts you by releasing norepinephrine and epinephrine and making you feel nervous, agitated, sweaty, pale, before you lose consciousness from your low blood sugar. Well, if you're on beta blockers, it's going to block the norepinephrine and epinephrine from doing that. So it can mask a hypoglycemic event in an insulin-dependent diabetic. So we wouldn't use a non-selective beta blocker in a diabetic for that reason, because it's going to block the effects of low blood sugar, which is going to be their warning sign that something is going wrong. So I think the other thing to remember with this group of medications, like most blood pressure medications, you can get orthostatic hypotension. You would never stop this drug abruptly. Beta blockers, you wouldn't stop abruptly. What's going to happen? You're suddenly going to have these receptors that are now going to be stimulated by norepinephrine and epinephrine, and you can get a rebound tachycardia and rebound hypertension. Okay, so that's not a good thing. So think of this as the prototype non-selective beta blocker. Okay, so let's just have a look at just some cardiac rules. Just some things to think about when administering medications that can affect the heart or blood pressure. Just some general rules to follow. So changing positions slowly. Whenever people are on cardiovascular drugs that can either slow down their heart or drop their blood pressure, when they go from lying down to standing, they can have significant orthostatic blood pressure changes. So advising changes in positions slowly, waiting until any symptoms have resolved. So say they sit up and they feel a bit dizzy, wait there until it resolves, and then stand up slowly so that the blood pressure is maintained to the brain, because that's what's giving you the symptoms, right, of dizziness, so you're not getting enough blood pressure, not getting enough blood to the brain. Another general rule is reporting a blood pressure of less than 90 on 60 to hold the medication and to contact the healthcare provider. A heart rate of less than 60 to hold the medication and call the healthcare provider, right? Some medications will make a heart rate of 60 significantly lower, such as beta blockers, and some other medications called calcium channel blockers. I'm not sure if these have been covered yet, but if they haven't been, we'll cover them. They also slow down the heart, calcium channel blockers. So it's an important number to think of. Well, they have a heart rate of 55, shouldn't really be giving them beta blockers or calcium channel blockers. Never abruptly stopping a cardiovascular type medication, because often you'll have rebound hypertension or rebound tachycardia after stopping a medication such as a beta blocker or an alpha-1 blocker. So always so if you see a question, or later on in life you see that someone's abruptly stopping their beta blocker or abruptly stopping their alpha-1 blocker, those need tapering over the span usually of about a week. Daily weights. So weight gain or weight loss of more than 2 pounds a day or 5 pounds a week to call your healthcare provider. So daily weights are important. It tells you, especially in people with, say, congestive heart failure, if you're gaining 2 pounds a day, that's going to be fluid. That's not going to be 2 pounds of fat a day. It's going to be fluid. That means you're potentially heading towards going into congestive heart failure. So daily weights, especially in hospitalized patients with cardiovascular conditions, not weekly weights, daily weights. Okay, so let's talk about another beta blocker, but this is a beta 1 selective blocker, meaning it's going to block the beta 1 receptors, but basically leave the beta 2 receptors alone. Okay, it won't block them as much. So it's going to impact the heart more than the lungs, which is typically what we want. We don't want you to block the beta 2 receptors in the lung, because you're going to get short of breath and wheezy. So they're much more popularly used, and they have the same effect of reducing heart rate, reducing contractility, and reducing electrical conduction in the heart. So they'll reduce cardiac output, so we can use them in hypertension to control high blood pressure. We'll use them in angina to decrease the workload of the heart, so that people don't get symptomatic chest pain in stable angina. And as previously mentioned, we do use beta blockers in congestive heart failure, in certain people with congestive heart failure. So the action, beta 1 selective, so the other term for it is cardioselective, right? It affects the beta 1, which are on the heart, and having the following effects there on the heart rate, contractility, and conduction. The adverse effects, all the beta blockers are basically going to have the same side effects, right? That GI side effects, that profound fatigue, and then the potential for bradycardia and low blood pressure. Same reasons to avoid them: bradycardia, heart blocks like AV block, and also if the person's already hypotensive, you wouldn't add a beta blocker. Nursing responsibilities is going to be the same as mentioned, monitoring vital signs, tapering the drug very slowly if the patient is going to get off it, following the cardiac rules, advising diabetics about not being able to know whether they're becoming hypoglycemic. This can block the sympathetic stimulation to warn you of hypoglycemia. It can also block someone who's going into shock because they're not going to become tachycardic from the beta blocker. And remember, beta blockers slow down the heart, and so do other medications like calcium channel blockers. So if someone's on a beta blocker, we'll think closely whether we want to add a calcium channel blocker, which is also going to slow down the heart and magnify the bradycardia. The other thing I'm going to mention with medications, so not just with beta blockers, or a lot of medications come in long-acting forms, so they have a coating on them that allows them to have a slow release over the whole day, so they can't be chewed. Okay, you can't break them down. They're extended release tablets, and they're meant to have a special coating on them. And if someone were to chew them, they could have profound hypotension if it was a blood pressure medication, because all the medication is suddenly being released. Okay, so that's it for this module. I realize it's a bit long. I try to keep to 2 hours and 15 to 20 minutes per module, but the autonomic nervous system is very large. I would suggest you get a good feeling of the different groups, such as the alpha 1. So there's 4 receptor groups. So there's the alpha 1s, alpha 2s, beta 1s, and beta 2s, and you can block them or you can stimulate them. And just to get a good idea of where the receptors are, because otherwise what happens as the semester goes on and also into next semester is that you're always going to be catching yourself about, oh, I can't remember that. Oh, I wish I knew my receptors. And it really does pop up throughout the rest of the nursing courses. So get a good feel for this module and the next one. I realize it's not easy.